Greetings. This is Maher Abbas from Dubai, the United Arab Emirates, and it's a great honor and privilege to be presenting at your conference today. I would like to thank the organizing committee for the meeting, for the opportunity and the invitation to do so. I'm tasked to discuss the topic of stent versus surgery for malignant large bowel obstruction. I have no financial disclosures to make. I am both a therapeutic endoscopist as well as a colorectal surgeon with over 20 years experience with endoscopic stenting. I do hope that I will present you with a balanced view, both from the perspective of an endoscopist as well as a colorectal surgeon. Now, back in 2017, this made headline news in the UAE. I stented a gentleman who was 100 years of age. He presented with a stage 4 colorectal cancer with a large bowel obstruction. He was treated successfully with an endoscopic stent, and this was such a milestone here in the Gulf region that it made the news. Now, we do know that 1 in 5 patients with colorectal cancer will present with a large bowel obstruction. Obviously, that percentage will go up in systems that perform very little screening and will be on the lower side in systems that screen routinely all patients for colorectal cancer. When a patient presents with a malignant large bowel obstruction, there are 2 issues at hand. The first issue is the acute abdominal emergency related to the obstruction. The second consideration is the long-term outcome of the cancer. Now, as surgeons, we have several treatment options to deal with the situation. We can resect the area of the lesion either through a subtotal colectomy or a segmental colectomy. We can perform an anastomosis with or without a proximal diverting stoma. In some cases, we may resect and bring an end stoma. There are some patients who are not suitable for resection, in which case we do a diverting ileostomy proximally, either in the small intestine or the colon. And on rare occasion, a patient may be suitable for an intestinal bypass from colon to colon or small bowel to colon, distal to the area of the obstruction. From an endoscopic standpoint, we can decompress internally either with a stent or a colonic tube. Now, even though we have several surgical options, it's important to point out that emergency colorectal surgery is associated with high morbidity and some mortality, especially when we deal with an elderly population. We do know from numerous studies that the stoma formation rate when we do emergency colorectal surgery is high, even in young people. And we do know that in general, approximately 50% of the stomas will never get reversed. They will become permanent, and this is even more relevant in patients who have metastatic disease, where the vast majority of them would never be reversed. A study from Spain looked at a decade experience with 83 patients who presented with large bowel obstruction. It's important to note that the rate of overall major complication after the surgery was 67.5% for any type of complication, with approximately 33% of the patient withstanding a major complication. Obviously, patients who had higher comorbidities, medical comorbidities, or anemic requiring transfusion had a higher complication rate, and 1 in 10 patients did not survive the hospitalization and died. It's important to know that older age and a high Apache score were also associated with a higher risk of mortality. The last 2 decades since I started this journey, the endoscopic stenting has been gradually gaining momentum, becoming a viable option with a high technical success rate. It is associated with many short-term advantages, including a lower stoma formation rate, a shorter length of stay in the hospital, a decrease in the amount of morbidity and mortality related to the procedure, and in patients who require chemotherapy, to treat their cancer. They can reach the chemotherapy faster if they undergo a stent compared to surgical intervention, as I will share with you with some of the data. Now, it's important to keep an overall perspective on the topic. Despite all advances, when we do stent patients with stage 4 disease, often this is a palliative stent. Many of these patients will not survive long term. This is my early experience with 52 palliative stent when I was in Los Angeles between 2003 and 2008. Within 4 months, 48% of the patient had died from the cancer, and median survival was 2 months. So we're looking at a group when we use stent for palliative reason with a very limited life expectancy. And the benefit of the stent is that we can tackle the issue at hand fairly quickly, getting the patient out of the hospital to their loved one sooner without much surgical morbidity. This study, published in Archives of Surgery from France, looked at time resumption of chemotherapy in patients who needed to have chemotherapy. They compared a group 31 stent with 27 patients who underwent surgical intervention. Those who underwent a stent placement were able to initiate their chemotherapy within 14 days compared to those who were operated, waited almost a month. Furthermore, a greater proportion of patients who needed to have chemotherapy received it in the stent group compared to the surgical group, 71% versus 59%. Now, this at this time may not seem like a great advantage with a limited life expectancy from current therapeutic agent being a few additional months, but as we develop more effective treatment in the future, this may become a very relevant topic, especially in terms of the impact on long-term survival in the patient who receives stent. But more importantly, if they live longer, they may also require a higher rate of endoscopic reintervention in relationship to the stent. This was published nearly 20 years ago, was about the early experience with the safety of self-expanding metal stent. And as you can see here, the overall complication rate was nearly 23%. These consisted of perforation, migration, obstruction, but important to note that mortality was very low, was 0.5%. This pooled analysis looked at nearly 1,200 patients in 44 studies. So clearly stent can be beneficial, but they're not without any risk, and I'll show you some of the more recent data. In terms of long-term complication presented to you here are 7 series from various countries, European as well as North American. The largest study was from the Mayo Clinic, where I spent 6 years of my career, and the long-term complication rate was 24%, meaning 1 in 4 patients undergo stent placement where the stent remain inside the patient. They will witness some issues with the stent over the remainder of their life. You see 10% either perforation, erosion, or bleeding in the Mayo Clinic study, and 14% risk of obstruction or migration. And these percentages can go up and down depending on the size of the series and the experience of the endoscopist, but in general, we do know that the Mayo Clinic study is fairly representative of what happened to these patients. And in terms of endoscopic reintervention rate, again, summarized here are 5 studies, not only from Europe, but Asia and New Zealand. And as you see here, the rate of endoscopic reintervention goes anywhere from 3 to 43%. In the Mayo Clinic study, 19%. 1 in 5 patients who underwent endoscopic stent placement at the Mayo Clinic required to have endoscopic reintervention at some point. Not only endoscopic reintervention, but also patients who undergo a stent may require to have surgical intervention. The picture in the bottom is a patient of mine from Los Angeles where I had to go back and retrieve the stent surgically due to an erosion problem. As you see here from the various studies, anywhere from 5 to 24% of the patient will require to have surgery at a subsequent date. And this is not the group of patient where we put the stent temporarily with the intent of doing surgery. These are patients where we use the stent with the intent of it being a definitive treatment long-term for the patient. Approximately 1 in 4 to 1 in 5 patients require to have surgery down the road. Now, what are the concern about the stent? Most of the data in the literature is currently retrospective with very little prospective randomized trial. We do know in terms of the major issue is cancer outcome. Obviously, a patient who have metastatic disease is not as important. What is important in those patients is what is the need for potential reintervention, whether surgically or endoscopically. But the group that is important from an oncologic standpoint is the group that is potentially curable at time of presentation. These are patients who present with localized non-metastatic disease with a large bowel obstruction. What is the potential risk of tumor dissemination if a stent is placed, especially if a procedure-related complication such as a perforation occur. Now, the Dutch study, the stent study, was a multi-center randomized trial with 1-to-1 ratio allocation, and it looked at 25 hospitals in the Netherlands over a 2-year period. These were patients who presented with left-sided malignant obstruction. They randomized nearly 100 patients in the study. The interim analysis was quite alarming. They did find an increasing rate of morbidity, 30-day morbidity in the stent group. And these were either related immediately to the procedure, such as perforation, or patient who failed the stent and needed to go to surgery. They tend to have a higher anastomotic leak rate and higher medical issues such as the pneumonia. And because of that interim analysis, they stopped the study prematurely and the trial was suspended. Now, in another multi-center randomized trial looking exactly at the same topic, the left-sided malignant colonic obstruction, but in this case, 30 patients went to surgery immediately, and 30 patients, the stent was used as a bridge to surgery. This was not used with the intent to palliate, but the intent to decompress temporarily and then move on to surgery. They looked at the primary outcome, stoma rate, secondary outcome, mortality, morbidity, length of stay. In this particular study, there were no difference in the outcome. However, there was a premature closure of the study as they had a high technical failure rate and placement of the stent, 53%, and they had a 10% perforation rate. Now, it is important to point out that this is randomized clinical trial, but from experience of centers that have done a lot of stent, typical technical failure rate in most centers will be less than 20%. Certainly, that is what I have witnessed in my own practice. Up to 30% is probably reasonable, but certainly not 53% technical failure rate. So probably the people putting the stent in the study did not have as much therapeutic endoscopy experience. A meta-analysis that looked at 4 randomized clinical trials, including some of the data I already presented, and they looked at patients where the stent was placed as a bridge to surgery over a 21-year period. 234 patients were analyzed. These were all with left-sided malignant large bowel obstruction. They looked again at primary and secondary outcome point, including primary anastomosis, the rate of stoma formation, death related to the intervention, secondary outcome including anastomotic leak, surgical site infection, and the need to reoperate within 30 days. The overall technical success rate was 71% when they combine all these studies, and the clinical success rate was 69%, meaning not only you were able to place a stent, but the stent was able to completely decompress the patient without the immediate need for surgery. Perforation rate was nearly 7%. However, they noted silent microperforation, 14%, that these typically do not require surgery. Often they are treated medically with antibiotic and medication. Now, the stent compared to surgery had a higher rate of having a primary anastomosis. So if you went directly to surgery with a large bowel obstruction, the likelihood of being put together through a primary anastomosis was lower than if there was a stent decompression first and then followed by surgery, certainly lower stoma formation rate. However, there was no difference in the permanent stoma rate, mortality, anastomotic leakage, or 30-day reoperation or surgical site infection. However, 3 trials were noted to stop prematurely. We already shared some of the data. Emergency surgery had a higher anastomotic leak in 1 trial, and in 2 trials, they saw higher stent complication rate and a higher 30-day morbidity. So 1 trial was against emergency surgery to against stent placement. Now, what impact does stent placement have on long-term oncologic survival? This was a retrospective review looking at approximately 13-year data. They looked at 48 patients who underwent a stent placement as a bridge to surgery. So the stent was used to decompress the patient temporarily, followed by surgery, versus 39 patients who went directly to emergency surgery. All of these, again, were left-sided malignant obstruction. And it's interesting to note that the 5-year cancer-specific mortality was higher in the stent group, 48% versus 21%. More importantly, the 5-year overall survival for patients who presented with no metastatic disease or perforation at the time of the emergency was lower in the stent group, 30% versus 67% 5-year survival for the patient who were operated. Obviously, this data was concerning that if you use a stent as a bridge to surgery, the patient may not do as well from an oncologic standpoint. The Dutch stent in 2 trial, 32 patients underwent emergency surgery versus 26 stent attempt. The stent was unsuccessful in 6 patients who were then transitioned to the surgery group. Now, they looked specifically at wire or stent perforation, which tend to occur in these 6 patients. The surgery group had a recurrence rate either local regionally or distant at 28% versus the stent group that had 50% recurrence rate. However, if you look specifically at the group that sustained either wire or stent perforation, the likelihood of recurrence was 83%. Again, another study that raised concern about the placement of stent in patients who are potentially curable at time of presentation. Now, do we have a physiologic explanation for this phenomena? This was an interesting study that looked at circulating tumor in the peripheral blood. They used the cytokeratin CK20 mRNA expression marker to demonstrate the circulating tumor cells. And they looked here at 3 groups. One group underwent routine colonoscopy for benign condition. They measured the level of cytokeratin 20 mRNA before and after the colonoscopy, and they compared them to a group that had colonoscopy, at which time a colorectal cancer was found, to a 3rd group that had a stent placement for the obstruction, and the 3rd group that had the stent placement had a much increased level of these tumor cells in the blood after the procedure. So that kind of raised the concern that maybe during the compression of the tumor with the stent and the manipulation of the tumor, that may disseminate some cell into the intravascular space and increase the likelihood of recurrence down the road. The European Society of Gastrointestinal Endoscopy in 2014 issued their recommendation on the use of stent, and the first recommendation was that stent is only recommended if you have complete obstruction. There were many studies advocating for the stent placement in any patient who has any degree of obstruction, and these recommendations go against that. Also, the use of stent as a bridge to elective surgery was not advisable in symptomatic left-sided malignant colonic obstruction due to the concern that patients are potentially curable, may have a higher relapse rate if an endoscopic stent is placed at the time of large bowel obstruction. However, if a patient is potentially resectable, but they have significant medical comorbidities, such as patient with a recent heart attack who just started anticoagulation after a coronary stent placement, or patient who may be recovering from a pneumonia or any major medical illness, the placement of a stent is reasonable in those cases because often the life expectancy of such patient is limited, and even though they may have a higher chance of recurrence rate from an oncologic standpoint, they may not live long enough to experience that negative aspect of stent placement. And certainly, if patients have stage 4 disease, regardless if they're young or old, regardless if they have medical comorbidities or not, a palliative stent is the way to go due to the limited life expectancy. Now, I venture to say, as a colorectal surgeon who dealt with this issue over the years, malignant colorectal obstruction is really a very complex issue. You will find in the surgical community supporter and opponent for the stent placement, but we must admit as surgeon that surgery is not perfect either. We see a lot of medical and surgical issues after surgical intervention in an emergency. I also would say that the technology continued to improve. When I started doing endoscopic stenting as a resident at the Mayo Clinic, the first stent we used was a biliary stent designed for the liver. We did not have any equipment at the time to tackle colonic lesion. Now, there are many companies that produce product and stent delivery device for the colon. So the technology over the last 20, 25 years has evolved tremendously and will continue to improve, providing us with safer and better tool. And certainly cancer care is also evolving. The life expectancy of patient continue to increase with various chemotherapeutic and immunotherapeutic medication. So it's very important not to fit all the patient in one mold, but to customize the treatment approach to any patient who present with the malignant large bowel obstruction. What is my current approach as someone who's been dealing with this for over 2 decades? I usually take into consideration 3 factors: the patient age, fitness for surgery, depending on the medical comorbidities. Also, the presentation. When I get called on a patient with a large bowel obstruction or a tumor, I will always get a gastrograph and enema to demonstrate indeed that there's either complete obstruction or near complete obstruction. Certainly, if a patient has any evidence of peritonitis, they need to go to surgery rather than endoscopic procedure. And the cancer location and the stage is very important. Patients with lesion in the splenic flexure are very difficult technically to stent due to the acute angulation of splenic flexure, and patients who have a very low rectal cancer also are not suitable from a technical standpoint. So typically, if you put your finger in and you can feel the tumor immediately, those patients cannot be stented because you need some normal rectum below the level of the stent to avoid discomfort for the patient or the risk of migration. So I'm going to provide you with an algorithm of how I approach this in my own practice. I look at the patient. Are they old and frail? Do they have significant comorbidities? And if yes, then if the patient has any evidence of peritonitis, if they have a tumor in a difficult location to stent, such as splenic flexure or distal rectum, or they have a complete occlusion where no lumen can be demonstrated by a gastrograph and enema, not even a string of contrast can go through, these patients will go to surgery. However, if there is no evidence of peritonitis, and if the tumor is not in the distal rectum or the splenic flexure, and if there is any degree of lumen through which I can pass a wire, then these patients will go for a stent. So that group is fairly straightforward. Now, if the patient, however, is young and does not have significant medical comorbidity, then what is the abdominal examination for the patient? Again, if they have any evidence of perforation from colonic distension or peritonitis, or if they have a tumor in the distal rectum, splenic flexure, or complete occlusion, these patients need to go to surgery. However, if not, then I would ask myself, is the patient potentially curable, meaning no evidence of metastatic disease at the time of CT scan of the abdomen? And if they are potentially curable, I will not put a stent due to the adverse oncologic outcome. Those patients I will operate on, accepting perhaps a little higher stoma formation rate, but from oncologic standpoint, it's what's for the best for the patient. However, if the patient is not curable and they have stage 4 disease at presentation, then a palliative stent is in order. Now, I have several publications on stenting and therapeutic endoscopy. I share with you 2 here, and the reference is on the last slide of this talk. If you need to know when and how to stent, the first publication seminar in colorectal surgery is fairly comprehensive and will give you a solid foundation to approach this topic. This was published around 2016 or 17. And the following study was for predictors of outcome for endoscopic colorectal stenting with over a decade data of what happened to these patients. It gives you a clear understanding when a stent is suitable and when not, especially from a technical standpoint. So in summary, ladies and gentlemen, both surgery and stent decompression are options for patients who present with large bowel obstruction. It is important to note that the judgment and knowing which patient to choose for endoscopic stent is of paramount importance to both short and long-term success, with a technical or oncologic success for the patient. It is important to know that these procedures require a tremendous amount of therapeutic endoscopy skills, so they need to be done by people who have extensive experience in therapeutic endoscopy with a gastroenterologist or colorectal surgeon in order to minimize any procedure-related complication and to optimize the outcome for the intervention. And finally, I would say that this area will continue to evolve. I presented to you our knowledge from the last 2 decades, and invariably and undoubtedly this will continue to evolve as a newer technology is released on the market and as the survival rate of these patients continue to increase with the newer generation chemotherapeutic and immunotherapeutic agent. If you have any question, clarification, or need advice about patient you're managing in your practice, regardless if it's large bowel obstruction or a complex colorectal issue, feel free to reach out to me. This is my practice email and my website there with the description of my practice in Dubai, United Arab Emirates, where I treat and see patients from currently 3 continents and from a radius of over 8,000 kilometers. I have patients who seek care here in my practice from Africa, Europe, the Middle East, as well as Asia. And finally, these are the references to the 2 studies. You can also Google my name. Under my name, you'll see several additional studies, but these are the 2 most important studies that if you have interest in endoscopic stenting and you'd like to get involved, these 2 publications can really give you a solid foundation of how to approach this topic. And with that, I would like again to thank the organizing committee for the kind invitation. I do hope that this talk was informative and that you have learned new knowledge and you acquire new knowledge for your practice in order to help patients with this complex condition. Thank you very much again.